Hello and good evening, everyone, and welcome back to our Sunday evening show of Iron Talks, where we discuss about iron and related issues. So far, we've discussed and covered a lot of different topics touching different streams in science, which are related to anemia and iron. Yet, after that, we come again with a very interesting topic relating to iron today, and which is anemia in children. I'm your host, co-host, in fact. My name is Karan Sharma, and let me call upon stage the eminent personality, Dr. Sanjay Kalra, who will be your host for tonight. Good evening and welcome, sir.
Good evening. How are you?
I'm good, sir. So before we give the stage to Dr. Sanjay Kalra, I would like to introduce sir. Dr. Sanjay Kalra is a DM endocrinology. He's done his endocrinology from AIMS, New Delhi. He is a past president for Endocrine Society of India. Dr. Sanjay Kalra is a president-elect South Asian Federation of Endocrine Societies. He is a board member for International Society of Endocrinology. Dr. Sanjay Kalra is the president for Indian Professional Association for Transgender Health. He has a lot of achievements and accolades to his name. Dr. Sanjay Kalra serves on the Research Society for RSSBI. He has over 1,000 PubMed indexed articles to his name and has fostered bilateral and multilateral links between various Afro-Asian countries in the field of endocrinology. Dr. Sanjay Kalra has developed the terms glucocrinology, lipocrinology, and the glucocopper tool to assess coping mechanisms. He is the winner for 2009 DAWN Dawn Award. Dr. Sanjay Kalra serves as an executive or has served as an executive editor from 2011 to 2015, where he worked to establish IJEM. IJEM has been rated as India's second best scientific journal according to Google metrics. So, very warm and good evening and a warm welcome to you.
Thank you, Karan. It's a
So,
very pleasant feeling, yeah, being part of Iron Talks, being part of this family. Yeah, carry on. You were saying something.
yeah, so I before I hand over the stage to you, I would just like to add one last point about Dr. Sanjay Kalra. Despite all of his commitments, he was traveling and he has been very busy with his schedule and he finds time to be on this show despite whatever he does. And that's what we respect about you, sir. And thank you for being the stage is all yours, sir.
Thank you. A warm welcome to everybody who is logged in. We have people from all parts of the country logged in. Now, when you look at traditional Indian history, when you look at Indian history, you are reminded of Arjun and you are reminded of Eklavya. So, Arjun was a student who had access to the best teachers. And Eklavya was a student who did not have access to teachers. We have so many people logged in today. Dr. Sanjeev Puri, Dr. Gauri Shankar Dharmaraj, all working at in small towns, villages across the country. They are the Eklavyas of today. But the difference between today and yesterday is now every Eklavya has the opportunity to connect with each other and to connect with the Dronacharyas of the country. I myself belong to the Eklavya category. I come from Karnal, which is a medium-sized town in a very small-sized state, Haryana. And when people comment, when people raise questions, when people say that I am working in a small village or in a small town, I have minimum facilities. It is not that I sympathize. I actually empathize. I don't even need to empathize. I can feel because I myself come from the same background. So no question is silly. Each and every question is important. And when you have a teacher like Dr. Mudita Dhingra, warm welcome, madam, Dr. Mudita Dhingra Dua from Kurukshetra in Haryana. A perfect blend of Dronacharya. Dronacharya, madam, this is the first time I've called a lady as Dronacharya, so please take it in the positive note. Someone who understands the pulse of Eklavya, someone who herself is an Arjun, and who herself is a Dronacharya. This is Dr. Mudita Dhingra Dua for you. Madam has done MD Pediatrics from the prestigious BGMC in Ahmedabad. Then her fellowship from the even more prestigious Wadia Medical College, Wadia Hospital in Mumbai. She is a fellow in pediatric and adolescent endocrinology and diabetology. Multiple credits to her name, multiple accolades, a reviewer, a writer, a researcher, and in the next 20 to 30 minutes, you will see a wonderful teacher. Dr. Mudita, warm welcome. We have seen that 40% of India's population is children, and roughly 40%, if not more, of India's children are anemic? So
Yes.
many questions coming in regarding this, and this theme about Eklavya, Arjun, Dronacharya, and you are a little bit of all of the above. While speaking, would you sort of be able to connect with all of us and tell us how the Eklavyas of India can manage anemia? And also, if you happen to be in a place like Wadia, perhaps, or like New Delhi, then how you can manage? So, warm welcome, madam. The stage is yours.
Yeah, good evening, everyone. First of all, I would like to thank Iron Talks and Dr. Sanjay Kalra for giving me this opportunity, and many thanks for the kind introduction. So, actually, I'm nobody, but I'm here to share my knowledge with you all. And this message should go to each and every person sitting in the village, sitting in the big city, and wherever the doctor is practicing, because anemia in children is very often undetected, and it is one of the cause of growth failure or growth retardation in a child. So as we know that children are growing, and the growth is going to happen only during the childhood period. So it is very important to detect anemia on time and to treat it with appropriate doses of iron and for appropriate time. So I will share my slides with you, and we'll continue with the conversation. So we'll begin with the basics first. First of all, what is anemia? So as we know that our blood has various cells, RBCs, WBCs, and platelets. I will go from the basics. So in RBCs, there is a protein known as hemoglobin. So because of that protein hemoglobin, the RBC has red color. So what is actually hemoglobin? It is basically a transport vehicle that carries oxygen from the lungs to every nook and corner of the body and gets back carbon dioxide to the lungs. So it is very important molecule and protein in our body. And whenever there is reduction of RBCs or hemoglobin, we call it as anemia. So now there is no specific cutoff for a definition of anemia, because in children it varies according to the age, and we'll see that further. So whenever there is reduction of RBCs or hemoglobin in the body, it is defined as anemia. So this is how a pathology slide would typically look like in anemic patients. On the right hand side, we can see the number of RBCs are very few and they are pale as compared to the left side picture, in which there are many RBCs and normal hemoglobin molecule. First of all, let's look into the symptoms of anemia. So symptoms of anemia in children can be vague. It can be completely asymptomatic, or in mild anemia, there can be irritability, crankiness of the child. There could be problems with memory, reading, speaking, mathematics, thinking, processing, problem solving skills of the child. And all these changes are very gradual. So it is very difficult to pick up these symptoms by the parents or the society, and they usually take it as normal. So mild anemia can present with very subtle symptoms, and it has to be detected only with the blood test. Only when the anemia gets severe, you can see the frank paleness of the body, as you can see in the picture, when we compare the normal pinkish hand, which you can see in the picture, with the pale hand. So this pallor is seen only when the anemia gets severe. Other symptoms would be poor appetite and poor gain in weight and height. So iron deficiency anemia is very common in children, and prevalence in children under 15 years of age is around 50 to 70% according to some data. And in India, if we talk, nearly 40% of preschoolers, that is 1 to 4 years of age, are anemic, 24% from 5 to 9 years of age, and 28% from 10 to 19 years of age. So almost one fourth of the population of children in our country is anemic. Now, how do we grade anemia? So, according to WHO grading of anemia, it could be mild if the hemoglobin level is 9 to 11 gram per deciliter, moderate if it is 7 to 9, and severe if it is less than 7 gram per deciliter. Now, coming to the age specific cutoff. Now, in a child who is from the age group 6 months to 5 years of age, normal hemoglobin would be around 12, and anemia would be defined as hemoglobin less than 11 gram per deciliter. So from 6 months to 5 years, 12 is normal, and less than anemia is less than 11 is gram per deciliter is defined as anemia. From the age group of 5 to 12 years of age, 13 gram per deciliter is the normal hemoglobin, and less than 11.5 is considered to be anemic. From 12 to 14 years, it is different for girls and boys. In girls, less than the normal hemoglobin level is 13, and in the boys, the normal hemoglobin level is 13.5, and less than 12 in both of the genders is considered to be anemia. And from the age group above 15 years of age, normal hemoglobin in girls is 13 gram per deciliter, and normal hemoglobin in males or boys is 15 gram per deciliter, and less than 12 is considered to be anemia in girls and less than 13 in boys. So coming to the causes of anemia. So the most common cause of anemia is dietary deficiency of iron. Now, dietary deficiency of iron is very common, especially when the diet is not balanced and there is excessive intake of cow's milk or animal milk. So as we know that cow's milk is deficient in iron, so children who consume a lot of milk, especially in the northern part of India, where the parents and grandparents are after milk, so that their child drinks a lot of milk to become healthy, but these children often end up being anemic. Other causes could be deficiency of folic acid and vitamin B12 in addition to iron. Other causes of anemia would be hemolytic anemia. So now in hemolytic anemia, the lifespan of the RBCs is reduced. Other different causes could be malabsorption or bleeding disorder, recurrent episodes of gastrointestinal infection because the iron absorption will be reduced. Any chronic disease can also give rise to anemia. For example, anemia of chronic kidney disease, or if the patient has chronic liver failure, that child will also be anemic. Then last and the rare disorders are the bone marrow disorders. So we know that hemoglobin is produced by bone marrows. So if there is any defect in the bone marrow, it can give rise to various forms of anemia like thalassemia, sickle cell anemia, hemoglobin D disease, hemoglobin E disease, and aplastic anemias, and rarely leukemias. So how do we classify anemias? On the basis of morphology. So morphology means the structure of the RBCs. So if the structure of the RBCs is normal as compared to the normal hemoglobin RBC, it is normocytic. If it is smaller, it is microcytic. And if it is bigger, it is macrocytic. And on the basis of cause, anemias can be classified because of blood loss, inadequate production of normal blood cells, or excessive destruction. So either RBCs are not able to produce in enough amount, or either they are produced but they are destroyed very early. So what are the determinants of iron absorption? So as we know that there are various types of iron, and heme iron, which is sourced from non-vegetarian food, for example, meat, poultry, and fish, it is better absorbed as compared to iron which is available from the plant sources. Also, there are various factors which plays an important role in the absorption of iron. So if we take vitamin C rich foods, for example, tomatoes, citrus fruits like lemon or cabbage, with iron rich food, the absorption of iron will be better. And on the other hand, if we consume milk products along with the iron absorption is going to be reduced. This also holds true when we consume tea and coffee with our meals. So the iron in the meal is not going to be absorbed fully. So we have to be very careful whenever we are prescribing iron-rich diet to the patient and the medicine also, because the patient has to take the medicine ideally in between two meals and not with the meal, because the iron absorption will be reduced. Now coming to the clinical manifestation, we have already discussed it in the previous slide, and one or two I will add more. Some of the children will present with eating mud, which is also known as pica. So it is a very common problem in small children. They will start eating mud or chalk or paint or cement or paper. So it is also a symptom of iron deficiency, and they should get their hemoglobin checked. Now, in a physical examination, it is very important to examine the child from head to toe. So how do we see pallor? The most important site to check for pallor is lower conjunctiva, then the skin, the mouth, the tongue, and the hands. We should also simultaneously look for jaundice and hepatosplenomegaly in the child, because it will suggest us the diagnosis of hemolytic anemia. Now, in lab examination, the first and foremost test which we go ahead is the complete blood count test, then the peripheral smear, RBC indices, retic count, WBC, and platelet count. So most of it will be covered in a complete hemogram. So only we have to order the complete hemogram and not only HB. It is very important to order the complete hemogram to get the detailed report. So now, what extra we can order whenever required apart from complete hemogram? Renal function test, serum iron, total iron binding capacity to diagnose iron deficiency anemia, and serum ferritin is also useful to detect the stores of iron in the body. So if serum ferritin is less than 12, it is considered to be iron deficiency anemia. Some other complicated tests are also advised in some of the patient, and there are some ratios which needs to be calculated to differentiate between mild hemolytic anemia and iron deficiency anemia. For example, Mentzner index. So how do we treat iron deficiency anemia? First of all, what is our aim? We have to restore the hemoglobin to the normal value as per the age of the child. We have to replenish the depleted iron stores. And we have to treat the etiological factor and prevent their recurrence. So most of the small children have a recurrent worm infestation because of the hygiene issues, and they should be treated with deworming agents at least twice a year. Even our government has a scheme for that, and most of the children are given twice in a year anti-helminthic therapy, usually on 10th February and 10th August. So all school-going children receive anti-helminthic therapy as a part of iron deficiency anemia program or National Deworming Day program. So how do we supplement iron? We have to first understand that we need to supplement iron in all children with anemia. So sometimes parents will try that, okay, we will give green leafy vegetables, hemoglobin will enroll, I don't want to give medicine. So that should not happen. We have to counsel the parents that already the child is anemic, the stores are going to take a long time to replenish, and already at that point of time the child's appetite is poor. So there are very less chances that the child's anemia can recover with the diet only, and child will definitely need therapy for iron deficiency anemia. So the standard dose which we give is 3 milligram per kg of elemental iron. It is usually given, it is effective in a single dose. However, it can be divided in 2 to 3 doses as per the tolerability of the patient. It has to be given in a certain gap with the meal. So around 1 to 2 hours of gap with the meal is sufficient. And proper therapy has to be prescribed to the patient. So usually it takes up to 4 to 6 months for iron stores to be replenished in the body. So the usual period of therapy will be 3 to 6 months depending upon the child's response. What are the outcomes, or what do we expect when we start iron therapy in children? First of all, that there is dramatic improvement in the cells of well-being observed within 12 to 24 hours of starting therapy. So the crankiness, irritability, and that feel-good factor comes in the child. Crankiness definitely goes down. In 4 to 5 days, the appetite also increases. And what do we see in lab? So around 48 to 72 hours after starting the therapy, there is increase in retic count because RBCs have started producing in a good amount, and it peaks in 5 to 7 days. The maximum response to oral therapy is inversely proportional to the severity of anemia. So if the child has very severe anemia, the response is faster Now, the average response of hemoglobin rise is at an average rate of 0.15 gram per deciliter, starting after 1 week of therapy initiation. There are various choice for iron preparation which can be prescribed to the patient. And in government supply, they have ferrous sulfate. However, ferrous fumarate and ferrous glycine sulfate are the preferred in our practice. So deworming already I covered, and children should be encouraged to wear shoes while going to the fields because certain helminthic agents can enter the body through the skin of their feet. Now, there will be some patients who will not respond to the treatment. We should know the causes of that. First of all, poor compliance is a very big issue. We have to ensure complete compliance. The doses have to be adequate and given for adequate period of time. Associated folic acid deficiency or vitamin B12 deficiency will also reduce the response to therapy. Or in addition, if there is malabsorption like celiac disease or chronic blood loss from the gastrointestinal tract, the anemia will continue to proceed. So how do we prevent iron deficiency anemia? Now, prevention of iron deficiency anemia does not start from the child itself. It usually starts way before that. So all the adolescent girls which are going to be, mothers in future, they have to be complete in their iron stores, and during pregnancy they need to take their iron supplements, and during lactation also. So if the baby is exclusively breastfed till 6 months of age and mother has adequate stores of iron, it is going to suffice for the iron supply for the baby till 6 months of age. And after 6 months of age, we must start complementary food with adequate green leafy vegetables or iron rich foods and a balanced diet. And definitely we can talk about food fortification because there are some products in the market or food items which are fortified with iron and iodine. So yes, multidisciplinary approach is required. Food fortification is very important, and we need to improve nutritional status of our children. So thank you. This is my last slide showing the burden of anemia in our children. So I will be happy to take questions.
Yes. Yeah. Thank you, Dr. Mudita. You've shared the burden of anemia and the numbers also. 40% of our population is children. 40% of all children are anemic. So something to remember by. You've talked of the definition, how to define anemia, how to diagnose anemia, how to work it up. And now let's see the questions. So lots and lots of questions coming up, and you have attendance not only from India but from Pakistan as well. So adab and salam to Meenam Inamji, who is watching from Pakistan. And Inamji, love and respect and best wishes from here also to Pakistan, and we pray for peace, aman, shanti all across the world. So har jagah aman ho aur har jagah sehat ho, tandurusti ho. Dr. Dharmaraj says, what is the drug of choice? You've mentioned that again, and you've talked about iron. So could you just repeat the favorite types of iron in the OPD for routine patients? And in case there is a special situation in pediatrics, then what types of iron can be used?
So like it will depend upon where you are practicing. If you are in a government setup, the iron supply is usually ferrous sulfate. And however, what I prefer is ferrous fumarate. So it is easily tolerated in children and the absorption rate is also good. And in some patients in which they have GI side effects, ferrous glycine sulfonate can also be tried. So these are the main preparations of iron which we can use.
You've also mentioned that the commonest cause is nutritional. Within nutritional, the commonest cause is iron deficiency. But yes, can anemia sometimes be a red flag in children? So when is it that I would worry? Maybe I see a sudden drop in hemoglobin, I see a severe hemoglobin, low hemoglobin, I see a symptomatic low hemoglobin. When is it that I should worry about non-nutritional causes?
Yes, that's a very, very important question because we'll understand if there is chronic iron deficiency anemia, the child will be asymptomatic because the body is adapted. So whenever there is sudden fall of hemoglobin, it can happen in various infections. It can happen because of bone marrow disorders like aplastic anemia. So what happens in aplastic anemia? Maybe because of some drug or maybe because of viral infection, the bone marrow stops producing RBC at all. So there is zero production of RBC and suddenly the hemoglobin drops. So in those cases, because the oxygen carrying capacity is suddenly dropped, the child can have dyspnea or breathlessness or difficulty in breathing, and it has to be taken very seriously. Another important condition which I would like to mention here is thalassemia. So, thalassemia, there are various forms of thalassemia. So, I'm talking about beta thalassemia here. So, there are two forms. One is thalassemia minor, and one is thalassemia major. So in thalassemia major, what happens is that around 6 months of age, 6 to 9 months of age, there is complete and sudden fall in hemoglobin level because the defective hemoglobin is produced, which is not enough to carry the oxygen in the body. So those children are dependent on regular blood transfusion for their whole life, and it is a genetic disorder which can be prevented by antenatal screening. So these disorders are red flags and they have to be picked up early. Another important cause in today's day will be dengue infection. So in dengue also there can be occult blood loss from GI also and internal bleeding also, which can drop the hemoglobin suddenly. So these are some important causes of sudden drop in hemoglobin, and these are red flag signs.
Also, greetings to you from Hoshiarpur, from Punjab, Dr. Sanjeev Puri. Dr. Gauri Shankar Dharmaraj, thanking you for your patient answers. And he says, could you just repeat the diagnostic criteria? You had mentioned that there is a difference in gender difference in the diagnostic. Could you just repeat that?
Yes, yes. So now I will mention just the diagnostic cutoff for anemia. 6 months to 5 years is less than 11 is anemia. 5 to 12 years less than 11.5. 12 to 14 years less than 12 in both the genders. And 14 to 19 less than 12 in girls is anemia, and less than 13 in boys is anemia.
So up till 14, it is just age-based, and after 14, it is gender-based, and it is the same as in adults. And
Yes,
we
so
should
less
not
than
be
12 and
satisfied. So, Dr. Mudita, question. Many times in the OPD, and Dr. Anshul Singhai is also logged in. He is a diabetologist from Bhilai in Chhattisgarh. So many times in the OPD, we tend to say, yeah, HB is 11.5, it is okay. Everybody in India, Pakistan has HB1C of 10, 11. So, Dr. Mudita, would you be satisfied with a 59% score in your examinations?
no. So we have to take into consideration the age group of the child, and as we know that 11 gram per deciliter hemoglobin is very very low for a newborn. So age specific criteria has to be followed, and
Yeah.
the whole hemogram report has to be seen in detail. So even if the HB is around 11 and there is MCV is low, MCHC is low, and there are clear signs of iron deficiency, those children even need iron supplements.
Will it have an impact on, so this question coming up, will it have an impact on scholastic performance? There is one girl who has a hemoglobin of 13, and there's another girl who has a hemoglobin of 9.5, but she is supposedly asymptomatic. Will that impact their performance in school, all other things being equal?
Yes, definitely. So anemia can have even long lasting and permanent effects in child's memory, reading capacity, and decision making, cognitive ability, problem solving skills. So all these areas are affected with anemia and deficiency anemia, and the effect can last longer even after treating anemia. So young children have to be treated early and adequately.
Because iron will supply oxygen to the entire, heme will supply oxygen to the entire body, including to the
Yes,
brain. And if your
yes,
child is anemic, it means the child is hypoxic. Just look at it another way, you are actually keeping your child in hypoxia. That is how to explain to the patients, to the family, that we need to give full nutrients to the brain, and iron is a method of delivering those nutrients. You can eat as
yes,
much as you want, but if it's not absorbed from the gut, and if it is not carried properly in the blood, it is not going to reach the vital organs.
yes,
Thank
that's
you
true.
from Dr. Ashok Sharma, madam, for a very simple but beautiful presentation. Dr. Farah says, madam, if patient is not able to tolerate oral iron, and then we have to give IV iron. So we have iron sucrose and we have iron FCM, ferric carboxymaltose. How often do we have to repeat, and how often should we do the iron studies?
Actually, with IV iron in children, I have very limited experience. During my residency, also, I've never used IV iron. Nowadays, iron preparations are very good. So, more in children, the tolerability issues they are not there. So maybe in adults it might be there. In children there is no problem. And now iron preparations are even available in a sachet form. So they can just drop those granules in the food itself, and the child doesn't have to consume any different medicine. So there are various acceptable forms which are available today in the market, and children they usually do not have any acceptability issue.
Syrups are available, and you can also try liposomal iron. One
Yes,
example of an oral preparation is Vitcofol HB, and the
yes,
beauty is that this is nano particle, so it will get absorbed very easily, and even the stool color will not change. And sometimes people
yes,
get upset with that.
yes. And
If it
GI
is
side effects are also very
if it is
less.
an adult, when you are giving IV iron, usually the effect will last for up to a year if you've done the calculation properly. So usually in the OPD, what we do, the book says you can check the iron studies after 6 months. Usually we check after 1 year. So I am trying to improve myself and tell the patient to come back after 6 months. Dr. Anand Purandare says in adults. So let me take this question. It depends. If it is a lady who is menstruating actively, and especially if she has heavy bleeding, then iron supplements should continue for a longer period of time, much longer than 4 months. If it is a male or a postmenopausal woman, then 4 to 6 months usually suffices. But the correct answer, if you want an honest answer and an accurate answer, that will come from transferrin saturation. You have to do the TSAT, the transferrin saturation or iron levels before starting the therapy. But in children, Dr. Mudita, how frequently is it in a general pediatrics OPD that you actually have to advise serum ferritin, transferrin saturation, total iron binding capacity? How frequent is this in the general peds OPD?
Very rare.
Very
Very
rare.
rare. Yeah, very rare. Only
Your
in cases in which we have doubts. Sometimes thalassemia minor and iron deficiency anemia can have overlapping pictures. So in those cases, we can order these tests. Even HP electrophoresis can be ordered in dicey cases. Suppose if the child is not responding, and then we have to order all these tests.
And you had alluded to this, but could you please confirm if what I'm saying is correct? If in the complete hemogram you are confused with all the numbers, the first number to look at is hemoglobin. The second is MCV. That will tell you whether the cells are big or small, and that will give you an idea of the differential diagnosis. And then the third number to check is MCHC to see actually how much hemoglobin there is per cell. Would this be a correct way, madam? 1, 2, 3, or can you improve upon this statement?
Yes, so everything is important, starting from hemoglobin, hematocrit, and MCV, MCHC, and platelet count, WBC count. So we have to interpret the whole report. And the most important here would be peripheral smear. So many times peripheral smear report, which is given in the printed report of the lab, it is not done actually. It is written on the basis of the MCV and MCHC report. So it is a good idea to get the peripheral smear reported by a hematologist or pathologist when we specifically ask for it. So we have to ask that hemogram with peripheral smear. So ordering a test correctly is also very important.
And you spoke of platelets and white blood cells. So this question from Dr. Sanjeev Puri, is pancytopenia common in the pediatric age group, and what are the common reasons that you see in a general pediatrics OPD?
Pancytopenia is very rare in pediatrics. If there is pancytopenia, it's a serious disorder. It can happen in leukemias and various bone marrow disorders in which there is reduction in the production of RBCs, WBCs, and platelets. It can also happen in dengue and some viral infections also, and some reaction to drugs, HIV and all. They can also cause pancytopenia. So it's a very serious disorder which can lead to serious consequences in the
Pancytopenia,
child.
aplastic anemia, chloramphenicol is one example which many of the more experienced physicians will be remembering. But even in today's world, alternative therapy, even allopathic therapy like methotrexate, there are many iatrogenic causes also of pancytopenia. and
Yes.
anemia. So be aware of that. Do take a drug history.
Hmm.
Dr. Anshul Singh, thanking you for your valuable guidance and also asking one question. Ma'am, you are a pediatric endocrinologist and you see so many patients. So you see celiac disease as well. Now, many of us struggle to suspect celiac disease. Screening will come later, confirming the diagnosis will come much later. But suspecting celiac disease and hemoglobin and blood health. Any comments, madam? Things which will make which will make us go to the OPD tomorrow and then sort of go with open eyes.
Yes, so if I talk about North India region, celiac disease is very, very, very common. So in any unexplained anemia or unexplained asymptomatic patient who is not responding to your iron therapy, then we must rule out celiac disease. It's a very common cause of malabsorption and chronic anemias and growth failure in children. So we must rule out celiac disease. They can present with no symptoms also. So screening is important, and they can have symptoms related to gastrointestinal tract, for example, frequent stools, loose stools, abdominal pain, and distended abdomen. So all these can be seen. However, they might not have any GI symptom and have only anemia. So it is very important to screen them for celiac disease.
So patient may be
If they're not.
asymptomatic. Yeah, patient may have GI symptom, and do suspect if you have anyone with unexplained anemia or poor response to routine anti-anemic therapy.
And
Short
severe
stature.
anemia. So if a child comes with a HB of 3 gram per deciliter, we must rule out other malabsorption syndromes also.
Also short stature or poor response to other aspects. You think it is nutritional short stature. You are sure it is not endocrine. And still the patient is not responding. Then again, think celiac. Also hypothyroid. You have given the best possible therapy. You are continuing to increase your thyroxine dose. Patient's TSH is not coming down. Then again, think celiac. So
Yes,
do
even
take a,
untreated hypothyroidism can give rise to anemia.
yes.
Yeah.
And another thank you, madam, from Dr. Purva Biswas. Good presentation and discussion.
Thank
So
you.
with this, madam, I'd like to thank you. Your patience and your expertise both tell us, and I'm sure everyone who is listening will agree that you are able to think like both Eklavya and Arjun, and you are able to, of course, teach like Dronacharya. For Inamji, who has logged in, Eklavya and Arjun are students from Indian history, and Dronacharya is the award we give to our best coaches. So, if you want to respect a teacher, you respect her by calling her a Dronacharya. So, with that, Dr. Mudita, we'd like to thank you very much. And you are addressing now entire South Asia. Any one take-home message? Our topic for today was anemia in pediatric practice, anemia in children.
So yeah, one take-home message which I would like to give here is we have to detect anemia in children actively and treat them adequately. So we have to catch them early and treat them adequately. Sometimes, the patient comes and we write a 1 month prescription, then the child is lost to follow-up. Parents think that, okay, we have given the treatment, but we have to explain the complete duration of therapy and then follow up the child accordingly. So yeah, I would like to thank the audience also for so interesting questions, and it's a pleasure to be here.
Thank you. And we hand over back to Team FDC. FDC does a great job behind the scenes of organizing this program.
Yeah,
Thank you, ma'am, and thank you, Dr. Kalra, sir.
thank
We actually had a very great session today because madam has covered almost 360 degree of pediatric anemia as well as the practical tips which he has given to even to celiac disease as well. With this, I think we thank madam for such a wonderful presentation and being a session, what we say, presenting the session today, and Dr. Sanjay Kalra for moderating the session. Thank you very much, sir.
Thank you.
thank
Jai Hind.
you, thank you.
Jai Hind.